Imagine booking, just a simple cosmetic laser treatment, only to have your doctor suddenly demand this invasive 6-month investigation into your internal organs
Yeah.
before they'll even turn the machine on.
Yeah, it's a huge shock for a lot of people.
I mean, if you've ever found yourself filling out a clinic intake form and wondering why your doctor needs to know the intimate details of your reproductive history just to treat some surface-level dryness, you are definitely not alone.
Right, because in the fast-growing world of vaginal rejuvenation, the screening process is, well, it's rigorous, it's invasive, and it is entirely non-negotiable.
Exactly, and that's exactly what we're getting into today. Welcome to the Deep Dive. Today we are looking at this fascinating collision between two completely different medical mindsets.
Yeah, on one side, you have the highly commercialized industry of cosmetic and functional gynecology, which, promises quick fixes for very real discomforts.
And on the other side sits the strictly regulated, meticulously monitored world of cancer screening and cervical health. So our mission today, we are pulling from a massive stack of sources to answer a very specific high-stakes question. Can an abnormal smear result delay vaginal tightening treatment?
Short answer is yes, absolutely.
Right, but the long answer is why we're here. We're cross-referencing clinical consensus statements from the American Urogynecologic Society, NHS screening guidelines, real-world protocols from clinics like Epiphany Dermatology, and some surprisingly blunt warnings from global regulators like the FDA and Australia's TGA.
It's a lot of ground to cover.
It is.
Yeah.
So to really get why this delay happens, we kind of need to start with the actual mechanics. Like, what do these treatments actually do to human tissue?
Yeah, so when clinics market vaginal tightening or rejuvenation, they're usually talking about energy-based devices, or EBDs.
Right, the lasers.
Exactly. They rely on fractional CO2 lasers, ERYG lasers, or radiofrequency. You'll often see them sold under brand names like the Mona Lisa Touch or CO2RE Intima.
And I think the word laser kind of tricks us. It tends to conjure these images of a sci-fi beam just cleanly zapping away problems. But looking through the clinical literature we have today, this is an intensely physical, almost brutal process at the cellular level.
Oh, it really is. The entire mechanism of action relies on controlled trauma.
Controlled trauma.
Right. These devices deliver photothermal heating directly into the vaginal mucosa, so they aren't just applying a gentle, soothing warmth.
No, definitely not.
They are generating enough localized heat to purposefully create microscopic injuries. In the literature, they call these microlesions, and they go deep within the tissue architecture.
Reading that, it honestly reminds me of aerating a lawn.
Oh, that's a great analogy.
Right. You take a machine and just punch thousands of tiny holes deep into the compacted dirt. It looks destructive, but that trauma allows water and nutrients to penetrate, forcing the grass roots to grow back thicker and more resilient.
Yeah, and the laser is essentially doing that exact same thing to the vaginal walls. That mechanical disruption is the whole point. By causing that thermal damage, the laser kicks off an acute inflammatory cascade.
So the body detects those microlesions and just rushes blood and immune cells to the area.
Exactly. It rushes vital nutrients there, too. And crucially, this heat shock stimulates fibroblasts. Those are the cells responsible for maintaining the structural framework of our tissues.
Right, the builders.
Yeah, the builders. It forces them to rapidly synthesize new collagen and elastin, a process called neocollagenesis.
So the old lax tissue is essentially dismantled, and this neocollagenesis forces the body to rebuild a tighter, thicker, more lubricated neighborhood.
That's the goal. It's used to treat laxity or severe dryness stemming from the genitourinary syndrome of menopause.
Which all sounds great, but it explains the incredibly strict prerequisites we see in the source materials.
Yes, because clinically speaking, you absolutely cannot initiate an intentional trauma healing cascade in a biological environment that is already fighting a pathology.
Right. I was looking at the protocols from the London Women's Centre, and they explicitly state that patients have to provide proof of a healthy pelvic exam and normal smear results within the last 6 to 12 months. An abnormal smear is an immediate, hard contraindication.
They will flat out refuse to treat you. The protocols are completely unyielding on this.
But wait, here's my question. If a patient is using a device like the Mona Lisa Touch solely to address, say, dryness at the vaginal opening or just the lower third of the canal, why does the clinic care so much about the cervix sitting way up at the top?
It's a fair question.
Like, why wouldn't a doctor just treat the lower half and leave the apex entirely alone?
Well, biologically and procedurally, you just can't isolate the vaginal canal quite that cleanly.
Really?
Yeah, I mean, the devices we're talking about use these cylindrical probes that emit thermal energy in a full 360-degree radius.
Oh, okay.
So, to ensure uniform tissue remodeling and to avoid localized scarring or uneven tension in the vaginal walls, the standard protocol involves treating the entire length of the canal.
Right up to the vaginal fornices surrounding the cervix.
Exactly. You are inevitably bringing intense heat into the immediate vicinity of the cervix.
Which brings us to the American Urogynecologic Society, or AUGS. They published a clinical consensus statement that addresses this exact geographical overlap.
Yes, and they mandate that before any EBD therapy, cervical pathology must be entirely excluded.
And the overarching concern they have is just the unknown, right?
Pretty much. We simply do not have the data to understand how bombarding precancerous cervical cells with photothermal energy might alter their trajectory.
Like, we don't know if the heat shock proteins generated by the laser could inadvertently stimulate abnormal cell replication.
Right. Or, maybe even more concerning for clinicians, it could make those abnormal cells harder to monitor.
Because if a patient is undergoing laser treatments, they're going to experience some degree of localized inflammation anyway.
Exactly. Inflammation, cellular shedding, and potentially spotting or light bleeding are all expected side effects of the laser.
But irregular bleeding is also one of the primary warning signs of a developing cervical issue.
You hit the nail on the head. If a patient with an active cervical abnormality undergoes a fractional CO2 laser treatment, the resulting inflammation and spotting completely muddy the diagnostic waters.
The clinician basically loses the ability to distinguish between a normal side effect of the cosmetic procedure and a critical red flag from a worsening dysplasia.
Exactly. It's a diagnostic nightmare.
So let's actually unpack the biology of that abnormality for a second. Because I think when a patient gets that phone call telling them their smear is abnormal, the instinct is to immediately picture a tumor.
Oh, absolutely. It's terrifying.
But looking at the sources, the reality in the lab is much more nuanced than that.
It is. Modern screening protocols primarily test the sample for high-risk HPV first.
Human papillomavirus.
Right. If that virus is present, then the laboratory technicians actually examine the collected cells under a microscope to look for structural changes caused by that viral infection.
And the sources throw a lot of acronyms at this stage. You read a pathology report, and it's just a wall of text. ASCUS, LSIL, HSIL.
It's an alphabet soup.
It really is. So if I see ASCUS on my chart, what is the lab actually seeing?
They're seeing squamous cells. Those are the flat cells lining the surface of the cervix that look physically atypical. The nucleus might be slightly enlarged or maybe irregularly shaped.
But it's not a sure thing.
No, the visual evidence isn't definitive. They can't tell if that cellular distortion is because of a temporary inflammation, standard yeast infection, or the very early stages of HPV activity.
So ASCUS stands for atypical squamous cells of undetermined significance.
Right. It's essentially the pathological equivalent of a blurry photograph.
Okay, but the picture comes into sharper focus with LSIL or HSIL.
Yeah, with those grades, the viral impact is undeniable. LSIL indicates low-grade changes. The virus has altered the cells, but the immune system is often actively fighting the infection.
And a lot of those cases just regress naturally, right?
Yeah, exactly. But HSIL, on the other hand, signifies high-grade changes. The viral DNA has essentially hijacked the host cell's replication machinery, causing the cells to multiply erratically.
And if they take a tissue biopsy at that point, they grade the physical depth of this abnormal tissue, which gives us the CIN scores, cervical intraepithelial neoplasia.
Right. CIN1 is mild, CIN2 is moderate, and CIN3 is severe.
CIN3 acting as a true precancerous state that requires physical intervention before it breaches the basement membrane and becomes invasive cancer.
Yes. But a really crucial context here is that the vast majority of these abnormal results do not equate to a cancer diagnosis.
I wanted to highlight that, actually. The statistics from Cancer Research UK make that really clear. They point out that only about 1 in 2,000 abnormal smears actually indicate cervical cancer.
That's a huge relief for a lot of people to hear.
Yeah. The smear isn't a cancer diagnosis. It's an incredibly sensitive early warning system. But the moment that warning system goes off, your timeline for a cosmetic laser treatment completely evaporates.
because the clinical priority pivots entirely to a procedure called a colposcopy.
Right.
A specialist uses a magnifying instrument to examine the cervix under bright light. They apply specific acidic solutions that cause any abnormal, rapidly dividing cells to turn stark white.
Which allows them to pinpoint exactly where to take that biopsy.
Exactly.
And if that biopsy confirms CIN2 or CIN3, we enter a massive delay in our timeline because we hit the physical reality of the standard treatment, which is the LLETZ procedure.
Yeah, LAETZ stands for Large Loop Excision of the Transformation Zone.
Yeah, it sounds intense.
It is. To prevent the high-grade cells from progressing, the clinician uses a thin wire loop, heated by an electric current, to physically slice away the diseased tissue from the cervix.
And they simultaneously use the thermal energy to cauterize the surrounding blood vessels. So let's just think about the mechanical reality of the body at this moment. You've just had a heated electrified wire physically carve tissue out of your cervix. You are left with an active, cauterized wound, an eschar, or a scab, sitting at the very top of the vaginal canal. The NHS guidelines for this healing period are intense.
Yeah, the body has to shed that scab and regenerate a completely new mucosal layer. Patients will experience distinct bleeding and discharge as that tissue sloughs off over a period of about 4 weeks.
And the medical directives during this window are absolute, right?
Totally absolute. No penetrative sex, no tampons, and nothing inserted into the vagina. The cervical stump is profoundly vulnerable to infection and physical disruption during this time.
Which means inserting a cylindrical EBD probe into that environment is just unthinkable.
Completely unthinkable.
You'd be taking a thick laser wand, dragging it through a canal that is actively shedding necrotic tissue and blood, and then firing thermal energy to cause thousands of new microlesions.
It would be a catastrophic clinical error. You'd be inviting severe pelvic infection or massive scarring.
But the delay stretches far beyond that initial 4-week physical healing window, doesn't it?
It does. Even once the tissue has completely regenerated and the patient feels entirely normal, the medical establishment still considers them to be in an active surveillance phase.
Yeah, looking at the NHS protocols in our stack, the patient actually has to wait 6 full months after the LLETZ procedure to undergo what they call a test of cure.
Right. The clinician takes another cervical screening sample to verify 2 things. First, that the localized excision successfully removed all the abnormal cells.
Okay.
And second, that the immune system has cleared the high-risk HPV infection.
And until the laboratory confirms a negative result on that test of cure, the patient remains categorized under active pathology management.
Exactly. You are still technically a patient in treatment.
6 months is a significant chunk of time to wait for a cosmetic procedure. But reading through the broader regulatory sources, the hypervigilance from these clinics starts to make total sense.
Oh, definitely.
It goes far beyond simply waiting for a wound to heal. The clinics are operating devices that the global medical establishment views with deep, profound skepticism.
Yeah, the regulatory history of energy-based devices in gynecology is incredibly fraught.
It's wild to read about.
It really is. In 2018, the FDA issued a sweeping safety communication explicitly warning against the use of these lasers for vaginal rejuvenation.
They noted they were not cleared or approved for treating symptoms of menopause or sexual function.
Right. And Australia's equivalent body, the TGA, went even further.
I read that. They completed a rigorous post-market review and concluded there was just insufficient clinical evidence to support the therapeutic claims being made.
The TGA actually canceled the registration of several of these devices, completely removing them from the Australian Register of Therapeutic Goods.
Wow. And in the UK, the National Institute for Health and Care Excellence, or NICE, they evaluated the available data and concluded that the evidence regarding both safety and efficacy is severely limited.
Yeah, they mandated that these procedures should not be offered routinely outside of special clinical governance arrangements or formal research trials.
The overarching theme from all these regulators is just the sheer lack of level 1 clinical evidence.
Exactly. We don't have the massive, decades-long, double-blind, placebo-controlled trials necessary to definitively map out the long-term biological consequences of repeatedly traumatizing the vaginal mucosa with thermal energy.
Because the vaginal mucosa is not just a thick layer of skin.
No, not at all. It is a highly complex, hormone-responsive mucosal surface. It's packed with nerve endings, vascular networks, and a really delicate microbiome.
And the complications regulators are tracking are not trivial. We are seeing reports of severe vaginal lacerations, chronic burning sensations, and debilitating scarring.
Yeah, one of the case studies cited in the NES overview is genuinely chilling.
The one about stenosis.
Yes, a patient underwent laser therapy and suffered such a severe runaway fibrotic response that her vaginal canal structurally collapsed.
She developed vaginal stenosis, where the tissue scarred and contracted until the canal was reduced to a rigid 2.5 centimeter fibrotic structure.
Right. Stenosis occurs when the neocollagenesis we talked about earlier, that intended healing response, goes completely out of control.
So instead of building flexible, healthy tissue, the fibroblasts just lay down dense, inflexible scar tissue.
Exactly. And when regulators are staring down the barrel of complications like irreversible stenosis, their tolerance for clinical risk drops to zero.
Which means the clinics that continue to offer these treatments are operating in a highly scrutinized, legally perilous gray area.
They are. If an adverse event happens, they have very little regulatory cover to hide behind.
Every major gynecological body dictates that conservative care must be the first line of defense.
Yeah, if a patient is suffering from menopausal tissue changes, the initial interventions should always be supervised. Pelvic floor physical therapy, high-quality vaginal moisturizers, and localized low-dose vaginal estrogen therapy.
Skipping those conservative treatments to immediately deploy an investigational laser on a patient who also happens to be harboring a diagnosed active cervical abnormality.
It's an indefensible medical decision.
I mean, imagine a doctor sitting in front of a medical review board trying to explain why they chose to fire a fractional CO2 laser just millimeters away from an active CIN3 precancerous lesion using a device the FDA explicitly warned against.
The liability is astronomical.
So those screening questionnaires that delay these treatments, they aren't just administrative red tape.
Not at all. They are essential clinical gatekeepers designed to enforce the fundamental principle of do no harm in an industry that, let's face it, often prioritizes rapid cosmetic results over comprehensive anatomical health.
So if you've been wondering why a seemingly simple aesthetic or functional tune-up requires such an invasive background check, the answer is rooted deep in your cellular biology.
Right.
An abnormal smear indicates that your body is actively fighting a viral intruder at the cellular level. And the diagnostic and treatment pathway that follows from the magnifying light of a colposcopy to the thermal excision of a LAETZ procedure, all the way through a 6-month test of cure, demands complete physiological priority.
Absolutely.
The foundation of your reproductive health must be entirely secure before you can even consider structural renovations.
You know, it leaves us looking at a really fascinating overlap in clinical tools. Think about the LLETZ procedure used to cure abnormal cervical cells.
Right, using a heated electrical current to actively cut away the dangerous tissue.
And then think about the energy-based devices used for rejuvenation.
Using photothermal lasers to purposefully injure the tissue and stimulate collagen growth.
Yeah.
Both interventions rely heavily on intense thermal energy to fundamentally alter the human body.
One to aggressively excise, the other to stimulate and rebuild. And the question we really have to ask is, what happens when a woman undergoes both of these procedures over the course of her lifetime?
Wow, yeah, it's like a thermal paradox. You could easily have a patient in her 30s getting her cervix excised with an electrified wire to prevent cancer, and then in her 50s getting her vaginal walls blasted with a CO2 laser to counteract the physical realities of menopause.
Exactly. How do those overlapping structural, cellular, and fibrotic changes interact over decades? We are manipulating the exact same biological neighborhood with extreme heat for two completely opposing reasons.
It's intense to think about.
It is a complex frontier of tissue regeneration in women's health that science is only just beginning to truly investigate.
It fundamentally changes how you view a simple intake form, doesn't it? You can't just mandate a localized tissue reconstruction without knowing exactly what that tissue is made of, what viruses it might be harboring, and what trauma it has already survived. Thanks for joining us on this deep dive, and we'll catch you next time.